Good morning, I'm Shannon Switkowski. I'm the clinic coordinator for Cardio-ECHO, and we are in week 11 of our Tackling Type 2 Diabetes series. I'd like to start out by inviting you to register or your colleagues to register for our upcoming series. It's a repeat of this current series backed by popular demand, January 14th through the April 1st of 2021. If you can go to the next slide, please. Okay. Please remember to chat your name in the attendance to record your attendance this morning, and mute if you're not speaking. If you're on the phone, the mute button is *6. We will go around and introduce our hub team members this morning, starting with Dr. Dungan.
Hi there, I'm Kathleen Dungan, endocrinologist at Ohio State University, and I'll be facilitating today.
Thank you. Dr. White Solaru.
I'm Dr. Khendi White Solaru. I'm assistant professor of cardiology and vascular medicine here at UH.
Thank you. Dr. Werner.
Yeah, I'm Jim Werner at CASE and UH and do behavioral health.
Welcome. And Dr. Wright.
Jackson Wright, Case Western Reserve, emeritus professor of medicine.
Good morning. And Dr. Gautam Rao, I don't see him, but he is family medicine physician at Case Western Reserve University and University Hospitals of Cleveland, and he will be joining us as well this morning. So I will turn it over to you, Dr. Dungan.
Hi, good morning, everyone. So this is the structure of our ECHO clinic. As in previous weeks, we will have a 25-minute didactic followed by a Q&A. We ask that you turn on your video and you may unmute your microphone when asking any questions, or you can put questions in the chat. That will be followed by our case study presentation and our wrap-up. And so today we'll be talking about type 2 diabetes in the context of cardiovascular risk. And this is our disclosure statements, and you should have received those by email already. And so today, here's our presentation. It will be given by Dr. Khendi White Solaru and Dr. Jim Werner.
Great, thank you. So learning objectives are listed here. We're going to describe the epidemiology of diabetes on a global, national, and statewide level. We're going to describe how diabetes increases the risk of cardiovascular disease, identify therapies that we use to treat diabetes and lower cardiovascular risk, specifically GLP-1 agonists and SGLT2 inhibitors, and when to use them. And then Dr. Werner will talk about smoking cessation. Next slide, please. So diabetes, the prevalence of diabetes is increasing. Currently, 500 million people worldwide have it, and this is expected to jump up to 25% by 2030. It increases the risk of cardiovascular disease and PAD and the risk for complications in those diseases. In the top 3 countries with prevalence of diabetes, China, the US is number 2, and India. Next slide, please. So in the United States, people with diabetes and prediabetes are at high risk for heart disease. And you can see here the statistics for those with diabetes, including undiagnosed diabetes and prediabetes, which is a lot. So the US population, this is to show on the left is the current demographics by ethnicity in 2020. And on the right, you can see the percent of people with diabetes from those ethnicities. So clearly non-Hispanic, Blacks, Hispanics, and Asians are very overrepresented, and those groups having greater than 20% diabetes. About 10% of all Ohioans have diabetes, so we kind of fall in that mid-range group, but getting close to the highest risk there. The highest risk we usually see in the South, the Rust Belt. So uncontrolled diabetes puts you at risk for heart disease and kidney disease. And this demographic, this shows clearly that the higher the A1C, the more at risk you are for heart disease as well as kidney disease. So it's something we all need to be concerned about. Next slide, please. Heart disease is the #1 cause of death in patients with diabetes. So you can see here the top causes of death for those with diabetes and ischemic heart disease is almost 10 million deaths, and it's certainly the #1 cause. So awareness, treatment, and control of diabetes in U.S. Adults. So here's a pie chart depicting those who have treated and controlled, treated and uncontrolled, not treated but aware. And next slide, please. So 80% of all patients are either uncontrolled, untreated, or unaware that they have diabetes. So clearly this is a big public health problem and an area for us to intervene as providers. So briefly, there's many organs involved with glucose homeostasis. You can see that the pancreas, the liver, the kidney, the gut, the brain, the adipose, and we actually have medications to treat all of these organs to help reduce hyperglycemia. But I'm going to be focusing today on two classes of therapies that have been shown to have some benefit in lowering cardiovascular risk, and that is the GLP-1 receptor agonist and the SGLT2 inhibitor. So the GLP-1 receptor agonist works to reduce appetite, reduce body weight. As I said, it lowers risk of ischemic cardiovascular events. It increases the production of insulin and increases subsequently the uptake of glucose. Also increases diuresis and natriuresis. The SGLT2 inhibitor does those things as well, but it also reduces the events of heart failure events, and it does not actually increase insulin secretion, but by a reabsorption mechanism, it increases glucose uptake. So on the left, the mechanism of action of the GLP-1 agonist, it basically delays gastric emptying, which increases, making you feel full. It also enhances insulin secretion, as we talked about, which leads to improved fasting and postprandial glucose and decreased hepatic glucose production. And that works in the gut. The SGLT2 inhibitors, on the other hand, work in the kidney. So the SGLT1, those receptors are more proximal, and that results in about 10% reabsorption of glucose, whereas the SGLT2 is located distally, and that accounts for about 90% reabsorption of glucose. So by inhibiting that, you have loss of glucose in the urine. So there's been many trials to look at these two drugs, and they've enrolled both cardiology patients and nephrology patients, chronic kidney disease patients with type 2 diabetes, and those with cardiovascular disease. And so we'll talk about some of those today. So the GLP-1 receptor agonist that we use, that you all might be familiar with, exenatide, liraglutide, albiglutide, and dulaglutide. And so these are just the doses that we use here. They do have, as in all medications, they have adverse reactions, including nausea, hypoglycemia, vomiting, diarrhea. The one thing that you want to be cautious about is using this in people who have a family history of thyroid tumors. It's not recommended because there is a link to the MEN syndrome, and then also pancreatitis. It puts you at risk for that as well. We try to avoid using these in patients with at least exenatide in patients with creatinine clearance less than 30, but you can use the other ones with renal dysfunction with no dose adjustment required. Next slide, please. The SGLT2 inhibitors that we use are canagliflozin, dapagliflozin, and empagliflozin. And so the doses are listed there. We really shouldn't be using these if someone's end-stage renal disease, any of these. And then hepatic dose adjustment, there's really no adjustment needed. And we usually administer this in the morning without regard to food. And then the one thing I will say, I tend to prefer empagliflozin just because it didn't show the limb events. So for PAD, it's a good choice because it didn't show increased risk of limb events like canagliflozin did. Next slide. So if this slide just basically shows that with all of the SGLT2 inhibitors, you do see improvement in hemoglobin A1C from baseline. So they do work for diabetes. Next slide. So the IMPA-REG results, you can see a significantly decreased risk of cardiovascular death compared to placebo. And so for the dapagliflozin, you can also see increased risk of cardiovascular death or hospitalization for heart failure. And so that's what this is showing you here, focusing specifically on reduction in cardiovascular death or hospitalization for heart failure, MACE, death from any cause, although it did cross the threshold there, hospitalization for heart failure, and death from cardiovascular cause as well. So canagliflozin, it did show a reduction in hospitalization for heart failure. So we tend to like to use these drugs for our heart failure patients. So comparing between the results, so they tend to favor strongly the GLP-1 receptor agonist for MACE and cardiovascular events. So this is the LEADER trial. Now we're switching here to the GLP-1, and you can see clearly that they have cardiovascular benefits, reducing the risk of MACE, cardiovascular death, non-fatal MI, non-fatal stroke. So the one other concern that you want to think about is just relative costs of these medications. So the SGLT2 inhibitors and the GLP-1 receptor agonists are more expensive, as you can see here, compared to your metformin, insulin. And so we still recommend first line using metformin, but in people who need additional agents or they can't tolerate metformin, the SGLT2 inhibitors and GLP-1 receptor agonists are a great choice, particularly if they have any risk for cardiovascular disease, which most diabetic patients do. And so then just a note about the renal function. So if their renal function is normal, you could really use any of them. But as the renal function deteriorates, I think that GLP-1 receptor agonists are your only option, and SGLT2 inhibitors become contraindicated at the lowest GFR.
Okay, so I've been asked to talk about approaches to smoking cessation. So go ahead, Rick. So it's really a teachable moment when a patient has a health-related event, such as a diagnosis, diabetes diagnosis, for example, or increasing disease severity or hospitalization. We know that these things will increase patients who smoke interest in smoking cessation. It triggers their attempts to quit smoking and improves their rates of actually quitting. And fewer, however, than 30% of patients actually use evidence-based methods to quit smoking. So we don't have a lot of patients using what we know is most effective, and that is a combination of behavioral methods and pharmacological methods. So 1/4 use only one of those methods or some other method. 15% try cold turkey. It's not uncommon, but it has a low success rate. 25% switched completely to e-cigarettes, which is another topic we can talk about if people are interested in talking more about that in the discussion. And 15% so got assistance from a health professional. Next slide. So the U.S. Preventive Services Task Force recommends that clinicians ask all adults about tobacco use and advise them to stop smoking, and then use behavioral and FDA-approved medications for smoking cessation. And this received the grade of A by the Preventive Services Task Force. It's recommended. There's high certainty that the net benefit is substantial. So they recommend offering this service in clinical practice. Next slide. Interestingly, most of you who are on this call, the evidence is strongest for what you do in working with patients. You're in a very advantageous kind of high leverage position because the evidence is strongest for physician and nurse advice for helping patients quit smoking. Telephone quit lines are also effective, and we'll talk about those in a minute. and as are tailored self-help materials. Brief one-on-one counseling of less than 10 minutes can be effective, and even minimal interventions of less than 3 minutes have been found to increase cessation rates. So there are a few things you can probably do in less than 3 minutes that could have a bigger impact on the patient's health than helping them quit smoking. Okay, next slide. You may be familiar with the SBIRT framework. It's been used to help patients stop using substances, and tobacco is a substance as well. It's been used across diverse populations. It's been associated in studies with increasing likelihood of smoking quit attempts and increased satisfaction with care. And like counseling, even low intensity SBIRT can prompt quit attempts and decrease cigarette use. Next slide. So I just want to revisit the opening the door technique that I spoke about when I presented on motivational interviewing. And this technique really follows the SBIRT framework very clearly. So it has a screening step, a brief intervention step, and then a referral for treatment. And we'll add a little bit of MI there at the end too. So I'll just walk through this. So, in the exam room with the patient, you can establish rapport, of course, and then ask about tobacco use. So do you currently smoke or use tobacco? Yes, I smoke. And then optionally, you can assess usage patterns and dependence level using instruments like the cage or the 4 Cs or the Fagerstrom instrument. But this is optional. But it can give you more information about how dependent the patient is on nicotine, how challenging their withdrawal may be from nicotine, et cetera, and the habitual patterns, of course, that go along with smoking that are probably even more reinforcing than the nicotine itself. And then the brief intervention component is to express concern. So I'm concerned about your smoking, and then link that to a medical problem that the patient has. So smoking makes it harder to control diabetes. It also increases your risk of developing serious health problems from diabetes. And then to solicit mutual concern. Does this concern you as well? In this case, the patient says, well, yes, it does. And then the step to collaborate, the offer to collaborate. Would it be okay if we discuss this for a few minutes today? Yes, that would be fine. So now then the final step here is a motivational interviewing step that I talked about a month ago. And really this is to assess the level of importance for the patient, to really find out about their readiness then to take the next step for referral to treatment, or perhaps they're not ready. So it's the 0 to 10 scale question about importance. Okay, next slide. So if the patient's willing to consider quitting or is ready to quit and is willing to talk with someone about that, you can refer them to the Ohio Tobacco Quit Line or SmokeFree.gov or other resources. So the Ohio Tobacco Quit Line will work with patients who are not yet ready to quit, or thinking about quitting, or have already quit and want to maintain their abstinence from cigarettes or tobacco. So they'll work with patients at any of these stages. So you can feel confident in referring them to the Quit Line that the counselors and coaches there are well equipped to work with patients in these different situations, as long as the patient is simply willing to engage with them about that. That's really the probably determining factor. Okay, next slide. If the patient's not ready to consider quitting or to make an attempt, there's some evidence that printed information, particularly if it's tailored to their needs or to a special population that they may be in, about risks and cessation methods, can be effective in helping them move through stages of change as they work with you and have repeat visits with you and revisit that. And most importantly, then, I think you can ask for permission to resume this discussion at a future visit. So leave the door open to, and hopefully the patient will be receptive to talk about this again. And that's one of the great things, I think, in medicine. You may not have the 50-minute visit that behavioral health people sometimes have to work with patients, but you have visits over time, repeated visits over time, hopefully, with patients. And that those interim periods are times when patients are thinking about what happened during the visit, what was discussed, and can help them move through the stages of change between visits. And that's an advantage that behavioral health doesn't have oftentimes. So it can be a very effective way to do this, and it may be why providers in healthcare are so effective actually in helping patients quit smoking. So during the subsequent visits, you can provide MI-based counseling to help them increase their motivation and their self-confidence in being able to quit. So patients generally will not make a quit attempt unless they feel fairly confident that they can actually succeed with it, a sincere quit attempt. Okay, next slide. So I thought this might be helpful. So there are a fair number of patients who want to quit, but on their own terms, because they feel like they understand why they smoke, they understand their own issues around quitting and cessation, and they really don't want someone from the outside directing them as to how to quit. So to maintain their autonomy, this director of tobacco research and intervention in Wisconsin recommends this kind of a framework for talking with patients who want to do that, to quit in a cold turkey method, so to speak. So he says, when patients tell me that they want to quit on their own, I try to build on their enthusiasm. So rather than opposing it directly and saying, this doesn't work so well, I'd like to talk with you about methods that will be more effective, he just kind of rolls with that resistance and says, what I say is, it's great that you want to quit cold turkey, but I want to give you a couple of tools that will increase the likelihood that your effort to quit is successful. I recommend you talk with the quit line and also take nicotine lozenges to take the edge off when you're quitting cold turkey. I don't try to change their mind. I just try to reframe what cold turkey can be. So he just simply reframes it that cold turkey encompasses also the quit line and nicotine replacement therapy. And that can greatly improve their chances of quitting. Okay, next slide. So the quit line uses phone, and it also provides online tools. So phone coaching and 5 phone visits with patients, calls with patients is standard, but they'll go with more visits than that, more calls than that if necessary, or fewer. They'll do phone coaching only, they'll do online only, with materials and quit planning and tracking the progress and so forth during the quit. And they also provide nicotine replacement at different times based on the availability that they have for that at any given time. But health insurance plans also cover this, and employers programs cover it as well. So next slide. SmokeFree.gov is a similar service in a way. It has the same objective, sponsored by NCI. And it really focuses, though, on smartphone apps, tailored texting apps and social media content. And it targets specific patient populations. So content is really tailored to general population, but also they have specific content for women, teens, veterans, etc. So it's very good in that regard, particularly maybe for patients who don't want to engage with someone on the phone. Younger patients are oftentimes very comfortable with using smartphone apps and getting information online rather than talking with someone on the phone. So it could be helpful for that. Okay, next slide. So your electronic health records may already be, systems may be set up for this, but you can refer patients through the electronic health record system to the Ohio Quit Line. Quit Line will also provide guidance for integration if your EHR is not already set up to do this. And to SmokeFree.gov also, and to other systems, so you can have it set up to do this. What's nice about this is that it then, the Ohio Tobacco Quit Line, for example, will initiate a call back to the patient. So you won't be relying on the patient to take the initiative to call the quit line. which is kind of a big hurdle for a lot of patients. Instead, the quit line will contact them and begin working with them. And that makes a big difference. Also, as far as adding another step to what you do in the clinic, care team members, other care team members, medical assistants, and other people can potentially, implement this referral process to the quit line and other resources by using, whatever route that works best for you, electronic health record, or they have an online form, or they can do it the old-fashioned way by fax. Okay, next. So again, recommend using the opening the door technique that we talked about earlier, which is really SBIRT consistent, and then adding just that one MI step about assessing importance and readiness. And then referring patients to the Ohio Tobacco Quit Line, SmokeFree.gov, community resources, or perhaps resources in your healthcare system. And for patients who aren't ready, ask permission then to resume this discussion at a future visit. Okay, so thanks for your attention. I think we're ready to move on to questions and answers.
That was really great. Thank you, Jim and Khendi. And I will open up the session to questions. Looks like we actually have one in the chat. Sherry Bolin says she likes the quit line. I thought I would mention freedom from smoking program info that you just got. Maybe we can share that after the clinic today. And National Lung Association's now offering this. Okay, and she offers a contact in there.
One quick question, Jim. Thank you for sharing all the info. For the 1-800-QUIC Now, when we're talking about the referrals, patients can self-refer themselves as well, just call and institute it. So I guess the practice workflow would just be so you get credit for it, or what's the benefit of making sure that it's implemented into the EHR?
Yeah, the patient can self-refer and call the quit line, and that's been the traditional way of doing it. The nice thing about the referral from the electronic health record or otherwise is that the quit line will initiate a call to the patient. So when the patient leaves the clinic and you maybe have agreed that they'll call the quit line, oftentimes, that's a big hurdle for a patient to actually do that. And so when you're making the referral, the quit line will instead contact them first.
Thank you.
Mm-hmm.
I have a question for Dr. Solaru. I'm glad you brought up the GLP-1 agonists. I think you alluded to using them as first line in some cases. And the more I learn about them with all the potential comorbidities they could help with, I'm just curious, metformin, we've learned that metformin's first line, but it seems like GLP-1s can quite often be used as first line. Is that right?
Yeah, that's correct. You can actually, for patients who qualify, you can use GLP-1 receptor agonist or SGLT2 inhibitors instead of metformin, but we still, per guidelines, it's still reasonable to use.
And just to follow up, other than like affordability and maybe fear of needles, are there other medical reasons why metformin is still considered first line?
It certainly is the cheaper of the options, so that might have something to do with it. But certainly I have, and it is acceptable for you to use GLP-1 receptor agonist or SGLT2 first line in appropriate patients at risk for cardiovascular disease or with heart failure.
There's a lot of literature about using SGLT2 inhibitors agnostic to hemoglobin A1C level. In other words, just as a cardiovascular event mitigation strategy, whereas metformin, I think, is still seen as a way to improve blood sugar control. But I was going to ask Kathleen to comment.
We have a long history with metformin, so still kind of remains first line for people who otherwise don't have known cardiac disease or extremely high risk.
Thanks. I will just add, I'm one of the cinema physicians here. So we see diabetes patients at risk for cardiovascular disease, and many of them I put right away on a GLP-1 or SGLT2, and I have not gotten pushed from insurance. So it could be, evolving.
We at Metro Health, we also have 340B pricing, which I believe other hospitals have, and liraglutide's available for I think like $10 for a few months. So.
Well, I have another question. Khendi, maybe you can address this. Since these SGLT2 inhibitors in particular are receiving expanded indications for heart failure and probably soon chronic kidney disease or different kinds of nephropathies other than diabetes, we're seeing a lot more use from a lot more, probably even more other specialties. And I wondered what your thoughts were in particular on patients with heart failure, how to co-manage all of these medications, especially some of them are on, several different drugs for heart failure and maybe even other comorbidities. Do we change the diuretic dose, or how do we monitor these patients?
Yeah, that's a good question. I think it's shown to be really beneficial for heart failure patients. So we're actually starting all of our heart failure patients that can tolerate it on these agents, and they tend to work really well. It doesn't usually require a reduction in the diuretic dose. It's usually just adding on to it, and it actually, if anything, they can usually helps. And so, as you mentioned, there is a lot of medications, polypharmacy involved with heart failure, but with the release of Entresto, and we are kind of consolidating some of the medication regimens. So, I think it's a good one to add on. Did that answer your question, or what?
Yes, thank you.
Okay.
Yeah. Other questions? Okay, and has anyone had any experience in the Freedom from Smoking program? Just kind of going back to that comment. Okay. All right, well, we will move on to our case. Yeah, other thoughts on that?
Where he works, what restaurant he's working in. You might be able to contact that place and just ask for him if you know that. Go ahead.
So he works at a fast food restaurant. I believe it's a Rally's. I would have to look in his chart. I documented it, but that's something that I could do. Reach out to the restaurant.
Darren, I just wondered if he has a support person at all where he lives, maybe someone that could be brought into the loop as far as his care to give him encouragement to make, hey, you haven't been to the doctor, why don't you give them a call, or just to encourage them to take their medications. Maybe a support person, or is there a community health workers that can be support people that could maybe help him keep up with his appointments. And the other thing I'm thinking is, you did such a great job of improving all his labs. I mean, kind of getting him to talk about does he feel better now that his A1C went from 13 to 9, and is it impacting his ability to do work and do what he wants for his family? And it's definitely decreasing his risk for a heart attack so that he can continue to be helpful to his family. So maybe having a conversation with him about just what a great job he's done for his health and how that's going to impact his life may, provide some motivation. I mean, you've reduced the costs tremendously for his meds. So, maybe just having him internalize it a little bit might help.
So
And this is,
I'm sorry.
oh, sorry, this is Sharon from the VA. The free clinic on the east side of Cleveland also offers a program for diabetes medication assistance when they can't pay for their meds. And that's on Euclid Avenue. If you just Google it, they have a some resources there. They will help with those medications. And I was wondering, did you ever put him back on metformin as well? Because that's dirt cheap.
Yes, so he is on metformin, max
Okay.
dose, and he's on Lantus as far as
Okay.
diabetic medications. And we were up titrating the Lantus, and then my plan was to slowly start thinking of adding pre-meals as well, but we didn't get that far yet.
But before you do that, you know, you should add the liraglutide if you can get it through the 340B.
Okay. And would that be with the 340B pricing? Is there a certain amount of medications that would be allotted through the 340B pricing?
Oh, I don't know.
Iridia.
So at our pharmacy, he can get 3 months supply, and it's Mark, you may know, it's like $10, $15. It's not more than that. So it's twice it. It's it's an injection you have to take every day as opposed to the weekly healthy one, which I wish we had on our 340B, but we don't yet.
Okay.
And Iridia, you might know, but there's a .340B smart phrase you can use and pulls up an Excel sheet with a list of all medications that are eligible on 340B. And you can also send an in-basket message to Care Coordination Pool and get community health workers to follow up with the patient.
That's awesome. Thank you. Thank you. So to add a little bit to your question, Karen, he does have his only support are his friends that he lives with. All of his family is overseas. He has a wife and his kids, I believe, are all overseas. Closest support are just friends that he shares an apartment with, that he's living with. Significant language barrier. He's Spanish speaking only, and relies more on his friends to set up appointments for him in the past, at least. He also does have moderate hearing loss as well. So it becomes for a longer visit, especially when using the translator phone. Sometimes it's echoing, he's not hearing well. So it makes for a longer visit in that sense too. And those are all barriers to care.
We had when we used to work at the free clinic, I used to work at the free clinic here. We had a restaurant employee that had she couldn't speak English at all. And she would have one of the other employees bring her, and he translated for her too. So that those people in the apartment, they could be powerful supporters for him. And, you could ask him, is there anybody in your apartment that maybe you can, can come with you to an appointment and translate, or use as a support system as far as getting here to the appointments. Maybe just putting the ball in his court. What is it you could do to get here? I just think maybe there is a way to get some support from people that live in the apartment, even though they're not family. They have an invested interest in him being able to work and pay part of the cost of the apartment, like a team.
And I guess my last thing that I don't know if Dr. Wright may be able to weigh in as far as his improving his lipid profile. So he had significantly elevated cholesterol and triglyceride levels. I have him now on 5 rates, statin, fish oil. Should I try to investigate if there's a familial component, or, I mean, to my knowledge, it's the treatment that he's on currently is the treatment, even if he did have a familial, which he likely does with those numbers.
Yeah, I think I would, one, that's a great question. Two, I think I would like to hear from from Kathleen in terms of the approach to this severe hyperlipidemia. He obviously he has had some improvement of triglycerides with the with improved diabetes control, as well as the medications that you already have him on. One of the questions in the additional question that I would have in this patient, I can't help you with where do you go with this patient in terms of testing, but the one question that I have is with these sky high triglycerides, would you are the GLP-1 inhibitors, are they in fact contraindicated, or what is the risk for pancreatitis in this patient with a triglyceride running 2,000 to 4,000? So bottom line is I can't answer your question, and are there others here that can answer that question? But in addition, I have the additional question.
Yeah, you know, it sounds like he has some kind of a combined hyperlipidemia. It might be, I mean, it is really high, so it'd be good to know what his direct LDL, and does he have tendinous xanthomas? That might suggest, I mean, certainly this is not classic for just plain old familial hyperlipidemia. He could have familial combined, or maybe familial combined plus familial hyperlipidemia. That you know, I have, but these are often very exquisitely sensitive to glucose control. I agree there might be some concern with maybe using a GLP-1 in this setting until you get the triglycerides down, but you did get them down to 2,000. So I might still argue that, you know, the benefits of using the GLP-1 maybe outweigh the risks in this case. But the other thing is, I'm not 100% sure if he's actually, you know, taking all of these meds. I guess that's also worth exploring to make sure that he's you know taking them consistently. If he had insurance, he has. I thought you said he has vascular disease. I would switch his fish oil to Vascepa because there's more clear cardiovascular benefits. But that's just kind of a small point. And then, you know, I think you're going to get more from kind of doing some of these glycemic control measures. I mean, you can optimize the fibrate, the statin, and the fish oil as much as you can. But he's probably going to need a PCSK9 inhibitor, and I don't know if there are any, you know, what the likelihood that he'll get coverage for that. So you probably want to get a direct LDL to see where he is.
Kathleen, did you say Tresiba?
Vascepa.
Vascepa. Is that what's that? What is that?
It's a fish oil that is enhanced in the DH. Somebody help me out here. It's DH. I think it's a DHA.
I thought it had both DHA and EPA, right?
EPA, DHA.
Yeah.
It has
So
both.
so it has better triglyceride lowering than the omega-3. That's what you're saying.
Not necessarily. It's just got more cardiovascular benefit with that enhanced profile.
And would you have somebody on statin, Vascepa, and a PCSK9?
Well, I think you have to get the direct LDL to see where you are first. But if his total cholesterol is still 400, it seems to me that his VLDL is very high, and it's driving all of this. So his ApoB levels are really high, which are very atherogenic. And so, I mean, yeah, I probably would do. I mean, in a perfect world, you would do that. I don't know that you're going to get him on all of that.
Yeah, you have to use pretty high doses of Levasa or Vascepa. I think it's like 3 to 4 grams per day. And there's a fishy smell to it as well, so not great tolerance.
Yeah.
And there's a lot of great discussion in the chat. We didn't get to all of that, but maybe that'd be something to review.
Well, this is Brian Batchelder. I know as resident, you need to do a home visit, and a home visit for this guy might be both influential, and then you can explore the home environment and talk with maybe even some of his roommates to see to ask for their assistance as well.
That's a good idea.
All right, well, that's a great discussion. Did you have any other questions that you wanted to ask the group, or Aridi?
No, thank you. I think we had a lot of great discussion. I think a lot of ideas were discussed. I just have to get in touch with the patient again.
Okay, great. All right, well, Shannon, I will hand the mic over to you for our wrap up.
Thanks, Kathleen. Thanks, everyone. Okay, so today you'll receive 2 surveys this afternoon, right after this clinic. So the first is our usual post-clinic survey, and then the second is a feedback survey. So there are 2 questions in the feedback survey. We ask that you complete them by tomorrow at 5 p.m. This will help us tailor the content of our week 12 clinic. In addition, I did want to say that we will have a presentation from Liz Beverly next week as well on the importance of language in diabetes, as well as addressing some of the feedback that we received from you from the final clinic. Next slide, please. Again, the post-clinic survey also needs to be completed tomorrow by 5 p.m. Next slide. And then next week, you'll also receive 2 surveys. It's the post-clinic survey as well as our final exit survey. We reach the end of our series next week. And then for those who wish to claim CME credits, you'll receive an additional survey from myevaluations.com. You will need to register on that website to begin the process of claiming CME. And you have until the 8th of January to complete that survey. Next slide. And lastly, please share with your colleagues. We are recruiting for our next series, which is the repeat of this current series backed by popular demand. And it starts January 14th and goes through April 1st of 21. So thanks everyone for joining today. I will send out an email with the resources that were listed in the chat today.